Good day, my name is Luregn Schlapbach. I'm a pediatric intensivist at University Children's Hospital Zurich, and it is my pleasure to talk to you today on how can we improve the healthcare system by improving care for patients with sepsis. I will present actually some strategies and information from the Swiss Sepsis Program as well, where I'm working on. What is sepsis? So sepsis arises when the body's response to an infection injures our own tissues and organs, leading to organ dysfunction. Sepsis is one of the leading causes of shock, multi-organ failure and death as well. However, it can be preventable in many cases if it is recognized and treated early. In Switzerland, it is estimated that there are roughly 20,000 sepsis cases every year, leading to an estimated about 4,000 deaths every year. This every year causes at least 1 billion Swiss francs of costs, right? So it causes a massive burden comparable to some leading cancer groups or myocardial infarction or stroke. However, where are we currently in terms of quality improvement in sepsis, and how can it improve the healthcare system overall? So in the talk, I will try and go through three key aspects. First of all, we'll try and understand why sepsis actually should be considered a systematic failure of our healthcare system to learn. We then actually discuss where can we learn from insights that have been gained in international quality improvement programs targeting sepsis. And finally, as well, we'll discuss how can we advance the quality of care for patients with sepsis in Switzerland, and what could be benefits as well that go beyond sepsis. So I'm a pediatric intensivist, so I will talk a lot about sepsis in children, but everything I will mention actually is not specific to children. It's just based on my own experience. What I will show you actually happens very, very often in adults as well. So when I talk to clinicians and ask who has ever experienced the death of a child due to sepsis, although everyone thinks it's relatively rare, most persons actually have experienced such. And what they remember when you ask them about these cases, what they often say that these children usually actually presented to healthcare, be that, emergency departments, hospitals, or general practitioners in the preceding days. And so often they say they've been overwhelmed by the rapidity of deterioration of these children. And very often actually the question remains sort of, what could we have prevented or done better? And so it's important to realize that sepsis is something that can happen to anyone, anywhere, any discipline, right? And this is a bit different from our healthcare system, where we think, the myocardial infarction sort of belongs to the cardiologist, right? The stroke belongs to the neurologist. But sepsis can happen anywhere, in ED, at home, on the orthopedic ward, in a rehab center. Very often when patients die of sepsis, what family members say is that they actually really were concerned, and they try and voice this concern, but often they say they have felt they were not heard. And when you talk to teams that have lost patients with sepsis, when we do these debriefs with hospitals that refer patients to us in septic shock, very often what they say after is that actually several team members, they were really worried about these patients. And sometimes team members, even in the middle of the night, they try to get help, but somehow, it did not lead to a point of recognizing sepsis and really actioning sepsis, right? And as a result of this, very often, people say that, okay, maybe actually this death potentially could have been preventable. And so let me start with a case here, and the mother has given me permission to show this picture here. So this girl that you can see here, roughly 1 year of age, up to the day before, was fully healthy, and then she started having a fever. The parents presented her to the GP, and on the coming morning as well, at 9 o'clock, they went back to the GP because they felt something was just not right. They actually said something is wrong with the child, the behavior is wrong, or something, we just, parents say they have this gut feeling essentially, that something is different about their child. They were sent home again with, some anti-fever medications, and at noon they were really worried because it's actually, she's just not looking right, and they phoned and they were sent to the regional hospital. In the regional hospital, in the emergency department, actually the patient is described as sleepy, the heart rate is very fast. This is a picture taken 7 hours after presentation. You can see the model appearance. And the mother several times actually sort of, spoke up to staff saying actually if someone would come and look that she was worried. Then 7 hours later, actually, then treatment is escalated. The first dose of antibiotics is administered, and she's transferred to ICU locally, and then actually to us as a larger hospital where she needs placement on the heart-lung machine, so-called ECMO. And unfortunately, within 24 hours, she passed away due to septic shock. And so one of the key questions here, of course, what happened essentially during these 7 hours in hospital and hours before? What opportunities could there have been to identify a deteriorating patient? And this is essentially what we want to focus upon. So sepsis has been called a disease of systematic failures to learn, because when you look at these cases, unfortunately, very often you see patterns that repeat themselves. Sometimes these are missed opportunities for prevention. For example, patients that acquire sepsis in healthcare settings, which could have been preventable. Very often when patients develop sepsis, either themselves or their spouse or their parents, they raise concerns. They say, actually, something is wrong, this is different. They describe that, something with the color is not right, or the breathing is more labored, or they say the patient is confused. But it's often difficult for family members to really voice these concerns, because either they may not be heard, but as well, parents and family members very often have never heard of sepsis, and they're not educated on sepsis, so it's hard for them actually to raise that concern. On the healthcare worker perspective, actually, this really leads to difficulties in recognizing sepsis, or as well to responding to the deteriorating patient. This can lead to delays in the diagnosis. This can be associated as well with some lab tests actually not being done or not being acted upon. A classic example are increased lactates, for example, when lactate is, let's say, 4 or 5 millimoles per liter, that then actually people say, well, it was a difficult blood sample, rather than recognizing this child actually is in shock and poorly perfused. Or there's been cases of children where emergency departments tried different blood pressure cuffs because they just can't get the blood pressure, but actually the problem is that the child is so shocked the blood pressure is very low. Often as well, there can be cognitive bias, thinking, well, the patient has had a viral infection for the last few days. Or, for example, the patient has myalgias, that they say, actually, this fits with influenza. However, actually, myalgia may be out of proportion. The patient is refusing to walk. And this is not taken in the context of a patient which is deteriorating, right? And all of this can not only lead to delays in diagnosis, but then as well delays in treatment, in particular time to antibiotics, and delays to escalation. And escalation at local level is very important to involve a senior medical person that takes action, that takes responsibility. But as well, escalation may involve as well actually transferring the patient to an ICU or transferring the patient to a hospital that has an ICU. And essentially, this all it keeps happening over and over again. If you look at root cause analysis published in Australia, for example, this is where we had been working on when I was involved in the sepsis campaigns there. They're often actually then public, or you have the coroner's reports. What you find in there repeats itself, and we have similar patterns here in Switzerland. And essentially can be summarized that we say actually sepsis is not an easy disease to pick, because we're exposed to a large number of patients that may have signs of infection, but in the beginning they look not too unwell. But this has to do as well that we're too willing to say, well, okay, it happened, we couldn't do anything, rather than say, you know what, we should improve. And we lack specific training on sepsis with having implemented specific tools to support actually standardized recognition, but as well treatment of sepsis. And let us just compare the reliability of how we perform there with something else. You all know Neil Armstrong, an amazing feat by humanity actually to achieve technically in terms of reliability and safety, achieving a landing on the moon. But Neil Armstrong died, just over 10 years ago because of pericardial tamponade after pacing wires were removed. This is a classic example of deteriorating patients, where patients become hypotensive, tachycardic, confused over several hours. Very similar to sepsis. So he did not die of sepsis, but actually what was found in the analysis of his death was that there were key features actually missed that relate to the recognition of the deteriorating patient. And Switzerland at this stage still lacks actually standards of how to recognize deteriorating patients, which has been recognized in the 2019 review on quality and safety in the Swiss healthcare system. And so sepsis is probably one of the most common reasons why patients deteriorate. And so if we improve care for sepsis, we probably can actually indirectly as well improve other care. And let us remember that we have done this successfully in Switzerland and in other countries for other diseases, so trauma, chest pain or stroke. There are clear standards, there are clear time frames, and there are benchmarks as well that EDs, for example, actually measure against. However, in sepsis, although it is a severely time-critical disease, it is still acceptable actually to just work beyond specific time frames. And so what can we learn from international quality improvement programs? This is a paper published in JAMA. There's a very similar paper published in New England just a few years ago, which essentially looked at the effects of the New York State sepsis mandate. There was, after the death of this boy, Rory Staunton, over 10 years ago, the state of New York had a law which demanded that every hospital must show three things. They must educate on sepsis their staff. They must implement actually a pathway to improve recognition and treatment of sepsis, and they must measure their data and actually report on their outcomes. And in the analysis of adults, as well as in this case here you can see of children, what they saw, if patients received timely treatment, in this case within 1 hour of the recognition of sepsis in a child, the mortality was reduced by 41%. Okay, this is an effect size that many drugs in healthcare never achieve. So this essentially shows the effect of actually doing this care well. What their analysis showed as well, both in children as well as in adults, that the compliance at hospital level with these benchmarks varied enormously by a factor which was several-fold, right? Indicating that there are vast amounts actually of potential to improve quality of care. But how can this be done effectively? And so different countries have taken different approaches. The UK has engaged by the UK Sepsis Trust in a very strong public campaign. The advantage of this, and their goal was really that the word sepsis needs to be in everybody's minds, that actually the public needs to start using this word. And they really encouraged, family members and patients and parents to say actually, could this be sepsis? Using very broad campaigns, very visible campaigns. The other thing which they did is that they had a relatively simple but highly standardized approach across the whole country in terms of recognizing sepsis and treating sepsis. These are just examples, some key signs for children, as well as on the right side saying actually what you should do. And they simplified this by 6 key steps. Now the advantage is that it did not matter whether you worked as a nurse or as a doctor in a regional hospital or in a large university hospital. Everybody actually was taught that way. And the hospitals, they could adapt it their way. So there could be, let's say the Liverpool or the London or the Birmingham version of this, but essentially, the core remained the same. So there was the creation of a same language across actually healthcare professionals, across institutions. And they encouraged actually healthcare workers to use the same. So could this be sepsis? Again, using the same term that they try and use in the public. Australia took a bit a different approach. So Australia, essentially, the Commission realized this is something problematic, a huge burden. And so they asked essentially an expert task force to set a standard which is required then as well for the accreditation of hospitals. So in Australia, the Australian Commission on Safety and Quality in Healthcare actually has about 20 standards which are key to measure quality and safety, but as well for hospitals to demonstrate what they do. And these are evidence-based, in this case for sepsis, actually standards that relate to what should be done on sepsis. And so the question is actually, how could this inform what to do in Switzerland? In Switzerland, an expert group just under 3 years ago launched the Swiss Sepsis National Action Plan with 4 key recommendations, and the first 3 are essential for quality improvement. It includes first, to spur awareness and education on sepsis, so that not only the public but as well that healthcare professionals have greater knowledge and proficiency on sepsis. The second point is that we need a national minimum standard, so a pathway, which supports both the recognition as well as the treatment of sepsis. And third, that we should think as well beyond the acute phase of sepsis, so that both the follow-up of sepsis and systematic support for survivors of sepsis and their families was essential. Then through this national action plan, actually we've been working with key national societies and then with the Swiss Federal Quality Commission, who then actually, thankfully 2 years ago decided to fund a 5-year program, the Swiss Sepsis Program. And this program is centered on several pillars. One key pillar being the promotion of sepsis advocacy and public awareness, the campaign starting now. Another work package has a strong focus on the education and training of healthcare workers, providing actually materials and e-learnings that can be used and deployed across the country on sepsis. And work package 4 is currently actually developing the standards, so a patient pathway to support the recognition of sepsis, but as well the treatment, and then well into follow-up. The intention being that this will be trialed and validated before then actually moving out into more broader implementation. And finally as well, and you'll see news on this actually in the next few days, the sepsis program actually has worked to create the first Swiss sepsis report, providing contemporary data from the last 5 years on the burden of sepsis on Swiss society, both in terms of cases, but as well in terms of mortalities and costs across all age groups. One key question which keeps coming up is actually, how can we do better in recognizing sepsis? And what's important to know is that there are a range of approaches used in Switzerland, but as well internationally. Where we come from on the bottom left is essentially the human approach. But we know that sometimes we fail, and it may be hard to see. We don't always have the same level of training. We may be distracted. What UK uses are cognitive aids, so simple paper-based charts. What is coming more and more through more sophisticated electronic health record systems are triggers embedded in the electronic health record, for example, triggers that relate on fever and fast heart rate. And more, and this will be the future, potentially actually the support from AI may make differences. But this all comes back down to saying actually, if I have a patient whose presentation is compatible with infection, do I have signs and symptoms which suggest that either in terms of the cardiovascular system or the breathing or neurology, that actually we have signs of the beginning organ dysfunction? So this is what we should mean when we say actually, think sepsis, actually could this be sepsis? Huh? An example of a pathway, comes now from Queensland, and this is actually what we're trying actually to create for Switzerland, is that pathways need to have different components. On one side, we have to support the recognition and escalation. On the other side, actually, a sepsis treatment bundle needs to be delivered, and this needs to be done in good alignment actually with antimicrobial stewardship, because we do not want to cause excessive or wrong use of antibiotics. And finally as well, we have to inform the patients and family members. However, we need to design as well then support that this leads into better handovers, better care after sepsis, and that it facilitates the recording of some essential data for benchmarking. So in order to do this well, what we need to think about is that it's important that we don't reinvent the wheel. So we can really simplify and reduce the workload for clinicians in Switzerland if we can create standardized training modules, which the sepsis program is done. And this should not just be medical, this needs to be interprofessional. And we need to think of ways that we use the same language, that we have like a core standard, however, allowing hospitals to adopt this locally. So they can save time, but they can still actually use and create something which then works better locally. But what's important is a lot of gaps that come up in sepsis cases really relates to other, let's call Swiss cheese model type aspects. And so there are huge opportunities that we embed sepsis quality improvement with systems of care to recognize deteriorating patients, so that the safety netting really can be used to reinforce good team practice. A good example is Speak Up. Cases of sepsis can be used and say, I'm actually worried about this patient, right? It can help us how we work with families that we recognize actually when they voice concerns. How can we take them more seriously? How do we approach that we handle sick patients? the use of safety huddles, for example, or the application of crisis resource management. The quality of handovers is very often comes up in sepsis cases, actually, because both in the recognition as well as in the handover, this is key, beyond as well the hospital, right? And finally as well, we can create a culture where cases are not only identified but analyzed and used as local sentinel cases to really promote learning. And often it is key that we can really shape local champions. And this means as well that we need to move beyond traditional quality management, which in Switzerland, remains heavily based on critical incident reporting and morbidity and mortality conference, which of course are essential. But we need to think as well of where can we use data, analyze the data, where can we really learn from sentinel events and use this to really inform educational, cultural management and targeted initiatives to change what we do. So in summary, what we think, actually, it is time that we change our mindset. Sepsis is very often a preventable disease or preventable outcomes. So the question is, how can we get better? And essentially, how can learnings from sepsis create a better healthcare system that maybe learns quicker? One part is, to really strengthen the partnership with patients and families and realize that it is an advantage if patients or the carers are better informed, that they can actually assist the recognition, but as well that we make them informed partners well into recovery and rehabilitation. In order to do so, we do need to improve how we educate healthcare workers, that they think more about sepsis, but as well that we educate them on using safety tools such as speaking up, closing the loop. And thereby, we're convinced that we can create opportunities for quality improvement which well go beyond sepsis, that hopefully can make a difference for how we recognize deteriorating patients, improve the safety netting, and eventually actually lead to better integrated systems of care. And with this, I would like to thank you for your attention and thank you all for helping to make a difference for patients.